let's turn back, though, to the issue. You said that about a quarter, even a little more than that, had gotten induction. I personally would not be a fan of intercalating consolidation chemo before the Durvalumab. Right. That's not how the trial was done, right. And it's not like there's a scintilla of evidence to support it. Sure. Induction was used, and I've talked with Mark Sosinski, who's done a lot of work in this, has raised the point that there are some potential advantages to induction, one being that you can get systemic therapy started at a systemic dose. Sometimes it takes a few weeks to get the chemo and radiation coordinated, and you can get a foot in the door while the SIM is going on and without losing ground. For some of my patients who I may have some reservations about their ability to do concurrent, we can make sure they're doing okay with the initial systemic portion. It was part of the trial. It was totally feasible. Right. And even though the CALGB trial going back a little over a decade was not positive, it did show a 2-month difference in median overall survival. It was not the most negative trial. I think it had some methodological issues in the patients on it. So it's hard for me to say that it would be an outlandish idea, and I think it is an option. Charu, your thoughts on induction? Do you do that for some of your patients?
So I do it for some patients. I think, again, going back to the point that these patients should be discussed in a multidisciplinary setting. And if there's something that's already telling me that I need to consider induction chemotherapy, maybe their burden of disease is a little larger than we would feel comfortable with encompassing in a radiation field, or maybe their borderline performance status, and I want to be able to just give them chemotherapy before I take them to combination chemoradiation. I think the decision should be made up front. I would hate for a patient to settle for a sequential approach when our intent was to do chemotherapy and radiation concurrently. So I think as long as it's discussed upfront with the patient that I'm going to watch you very closely, but my intent is still to take you to chemoradiation, I think it's a very fair strategy to do that. And I think totally in line with what was done on the trial to still come back with the Durvalumab. Going back to the timing issue of how and when to start Durvalumab, I will just add that I agree with you that it was maybe those patients that were going to do better anyway because they were either better performers, low burden of disease, younger, healthier, fitter. But I think as medical oncologists, we should also be able to prevent delays. And I feel that sometimes the chemotherapies that we may administer may delay things. I think cisplatin etoposide can delay my administration of Durvalumab, even if I didn't want it. And I feel like carboplatin and paclitaxel may make it easier because I'm monitoring their counts every week. I'm seeing them every week. I have the ability to hold chemotherapy or delay it or defer it. Yeah. And I feel like that's probably the most controlled environment I have as a medical oncologist. Yeah. That's just how I feel.
I agree with you. I think, again, that's one of the reasons I don't want to do a lot of consolidation chemo right after chemo-RT, because you could delay initiation of immunotherapy, which I think is the key here. So I'm not really in favor of doing consolidation chemo after chemo-RT. So in that point, I absolutely agree with you. I think going back to the induction, I've never done it. In our institution, that's not standard of care. We sort of interpret the CLGB study as being basically a negative trial. I see Mark's point. I've had discussions with him also, and I agree that he does raise a couple of good points. My biggest question is, do you need it? Yeah. And that I don't have an answer to, because we really didn't design a trial to look at those specific kind of questions. And I think, again, you're coming out making a recommendation about how to treat the patient when you don't have the data. It's kind of hard. Yes, you can do it. Yes, it was not on the study. Obviously, it wasn't detrimental, although we don't have the details of those 28% who got the induction and what happened to them. I don't see anything wrong with them. I would just argue that, the data is not very strong in support of doing induction. But patients like you mentioned, if they have a lot of disease burden, I've never been a big fan or a believer in downstaging, so to speak, with chemo, because you know, you use carbotaxol a lot in the metastatic setting. How often do you see that wonderful of a response? Yeah, occasionally it can happen, but this concept of downstaging and making it a little bit smaller, I never bought into that, honestly. So we haven't, or I haven't tried that. And I know a lot of my colleagues, at least at Fox Chase, don't really do a lot of induction up front. But again, because it was part of Pacific, I have no objections if somebody wants to try that, right?
Well, I have had an occasional patient for the reasons I mentioned, and also for the question of, yeah, you could do it with the radiation field that's there, but it wouldn't bother me at all if it shrank and it was a smaller radiation field. And in fact, the last person I've done this for, that's what happened, and great. Let's turn to the timing of the Durvalumab. In the study, patients would get imaging after chemoradiation if they had not had progression or toxicity issues or a drop in their performance status would go on to the Durvalumab. My standard timing for doing the post-chemoradiation imaging was about 3 or 4 weeks after, so that we could see the extent of the radiation effect, which often extends beyond a week or two. I have tended to shift that a little earlier, just trying to get the Durvalumab started a little earlier. Not that I think it's critical, but just because there seems to be a little more of a gravitational pull toward, if you can get it done quickly in the wake of chemoradiation, maybe that is a good thing. Have you changed the timing of your imaging, and what's your goal for starting Durvalumab? I mean, would you want to start it a week later? Would you feel no issues at all if it's 5 or 6 weeks?
Yeah, so I completely agree with you that it used to be 3 to 4 weeks in the days when I was using consolidation carbo and paclitaxel. I used to have patients come back at about 3 to 4 weeks, get a scan, they look good, they've recovered. Okay, now you can start your consolidation. I have started moving that up a little bit. I am getting restaging scans at about 2 weeks. I feel that, you know, at 1 week is probably still too early. I think patients are just sick of coming every day by that time. Yeah. And, you know, they just want a couple of weeks to just relax and not see us, which is fine. I don't take it personally.
My patients love seeing me, so it's a little different.
I don't take it personally.
Go ahead.
So I think 2 weeks is probably my goal, and I'm trying to meet that.
Yeah.
I was saying, let's just remind everybody that our radiation oncology colleagues don't like the CAT scan that soon, right? But we're doing the scan to make sure there's no evidence of metastasis, really. We're not looking for a response.
Yeah,
and I do mine in 2 weeks also to start Durva, so that's been my practice.
And I'm thinking the same thing, that back when this was the only thing that we were relying on, and there was nothing necessarily to follow it, it mattered more to us than now. The hurdle being no progression, good enough, let's keep going. Yeah. So, and then we get to take credit if it's continuing to shrink, so much the better.
Yeah.